No population group has suffered more for our confusion and conflicts than have older people. The organic, psychological, and social changes associated with late life do not automatically produce mental illness. Quite the contrary. The great majority of older people live competently in some community. Yet older persons are at risk for behavioral and emotional disorders, particularly those disorders that lead to institutionalization.
You are listening to Dr. George Maddox, Director of the Center for the Study of Aging and Human Development at Duke University.
In the area of mental health services, older people illustrate the all or none phenomenon. They get too few preventive and maintenance services and too much institutionalization. Our notable failure to produce adequate mental health services for older people is compounded by some correctable conditions, however. Prominent among these correctable conditions is an incorrect assumption that older people cannot be helped. That is wrong. We not only know better, but we also have some knowledge about what can be done. And that is what this conference is about.
The time is late May of 1975. The place is the campus of Duke University. And the conference Dr. Maddox referred to was one of a number of action-oriented national meetings which have been organized over the past 5 years under the direction of the Older Americans Resources and Services Program of the Duke University Center. The theme of the conference was Successful Treatment of the Elderly Mentally Ill, and it was supported in part by a grant from Wyeth Laboratories. Selected portions of the conference proceedings were recorded. Workshops, clinical papers, and discussions, and conference group leaders were interviewed individually. Wyeth and the Duke Center are pleased to bring you this first in a series of tapes edited from these sources.
We know a good deal about how to modify individual psychotherapy to make it applicable to the elderly. We know a good deal about how to modify group therapy approaches to make them applicable to the elderly. We know that drugs are useful with elderly patients also, and very useful in fact, but that certain modifications in treatment approaches to the drug therapy of elderly patients must be made in order to get the maximum benefit from these agents.
That was Dr. Eric Pfeiffer, organizer of the conference and Associate Director for Programs at the Duke Center for the Study of Aging and Human Development. Dr. Pfeiffer will be our guide to these audio cassette discussions. This tape will focus on the first of the treatment modalities he just mentioned, how to adapt individual psychotherapy to treat elderly patients successfully. The two other approaches, group therapy with elderly patients and treating older individuals with somatic therapies, will be the subject of future tapes in the series. Dr. Pfeiffer, in your introductory remarks to the conference participants, you said that we know a good deal about how to modify individual psychotherapy to make it applicable to the elderly. The idea of using psychotherapy at all with anyone beyond middle age is something new, isn't it?
Yes, I would say so. Until recently, it was generally believed that older patients were not responsive to psychotherapy. One reason for this, of course, was that relatively few people tried. Another reason was that Freud himself had said many years ago in a journal article on psychotherapy that older people could not be treated psychotherapeutically. Now, the amazing thing was that by older people, Freud meant anyone over age 45. Now, while Freud was undoubtedly a profound genius and one of the great developers of the field of psychiatry, he was certainly wrong about that. We know today that older people are in fact responsive to psychotherapy. They experience conflicts and crises which require solutions. Currently practiced forms of psychotherapy, with some modifications, are effective in resolving some of these crises and conflicts.
The kind of psychotherapy that I use most is supportive psychotherapy, insight psychotherapy, relationship psychotherapy, the duration of which is much shorter and is all that is needed in a lot of situations, like crisis situations.
Carolyn Welborn, whom you just heard, is a psychiatric social worker in our Older Americans Resources and Services program, serving people 50 and over here in Durham, North Carolina.
My experience has shown that individual psychotherapy does work with older people, that with some older people it can be very successful.
I think we have to define what we are calling psychotherapy, and the classical approach may not be as effective with the general group of older people. Certain modifications are important.
Dr. Daniel Peake is a psychiatrist in the OARS clinic. That's short for Older Americans Resources and Services Program, a division of the Duke Center for the Study of Aging. He and Carolyn were discussion leaders in the conference workshop devoted to individual psychotherapy with the elderly mentally ill. As a kind of quick guide to this new area, during the next 20 minutes I'll discuss with them the kinds of things they feel it's important for the practitioner to know. First, though, it may be helpful for the listener to know the setting within which they practice. As Carolyn said, the treatment model is that of a multidisciplinary team, operating much as a mental health center would. Now, about the age of the patients. How old is old, Carolyn?
The youngest I've worked with, I think, was 51, because we have a cutoff point of age 50 in our clinic. The oldest, I think, was 78. But I think the chronological age is not the most important age. Sometimes the age of the problem that the person has, the duration, the age and the severity and the nature of the problem is as important to consider as the age of the person sitting in front of you.
All right. Now, Carolyn mentioned that it's frequently a crisis which brings the older patient into the clinic, and most forms of crisis therapy are time limited. Do you put a limit on the number of visits within which you will work on this problem, Dan?
Well, this may come as a shocker to some people, but I think one must give an indefinite commitment to an older patient in terms of treatment.
That, I think, is the major difference between this type of therapy and brief therapy, say, with a younger individual, or crisis intervention as it's usually conceived. We'll come back to that in a minute. But why don't you outline the process, the phases through which the treatment takes place? Carolyn said that quite often there's a crisis.
The crisis brings the older person in, and there's a flurry of activity. One gathers a lot of information. It's necessary to do a comprehensive evaluation. It's important to look at the physical aspects, the social aspects, the mental aspects, the economics come into play, and certainly the activities of daily living are important. And one must know something about that whole picture, and then how the mental problem fits into that context.
What you're actually saying is that rather systematic evaluation of the individual is needed before starting out on a treatment plan. Now, I take it that you found that evaluation of an older person is not necessarily easy.
Frequently what you're dealing with is a resistive, distrustful, suspicious older person that really oftentimes doesn't really want to come to you, particularly if they know you're a psychiatrist or someone that's going to call them mentally ill. You try to get across to them that I'm really interested in you. I'm interested in your problems. I'm not going to put you in a hospital necessarily. I'm not certainly going to call you crazy. So this first phase is there's fairly intensive contact, at least weekly, that you would see an older patient for probably about, I say, a month.
Older people tend to have multiple problems. Part of therapy involves partializing the problem, dealing with one problem at a time, because when they have multiple problems, it gets to be very overwhelming to them. And if you can work on one thing at a time, saying, okay, you've got this problem, and over here's another problem, but we're just going to have to work on one of them at a time.
It's not the same with younger people, where you can go for months and months and sometimes years and not really delineate what exactly the problem is that you're dealing with. Older people, in some respects, are easier to treat in psychotherapy because you don't have to unearth the nuclear problem necessarily. In other words, go back to year one with them.
All right, then. You identify the immediate problem relatively quickly in 3 or 4 visits. What next?
A reinforcement phase, reinforcing the healthy patterns of behavior and coping with these emotional problems, whatever they might be, and solidifying and reinforcing them, and I call that the phase of reinforcement and solidification. That generally lasts about, I say, 2 months in addition to the first month I mentioned. So that's about 3 months into treatment. And we've looked at our cases in the clinic, and it seems by that time resolution is pretty well underway, or in many cases complete.
But you began by saying you make an indefinite commitment.
But then the phase of maintenance occurs, and that goes on indefinitely. A visit once in 3 months, once in 6 months, once a year. But you do need to promote the idea that there is an indefinite commitment to help them in some manner or means if they're going to need it in the future. You don't send them away and say you're cured. That's the last I want to see of you. That is poor treatment. And essentially that's what we've delineated in our group.
A lot of times the reassurance alone that you are there, that if they see you as a helping resource, if they know that they can call you and that you are there if they need you, is all that's needed. And they may call you in between the 3-month span before the regularly scheduled appointment. But just knowing that somebody is there, I think, helps a lot.
And incidentally, in that phase, the telephone can be used to good advantage. In our workshop, somebody was telling us about a patient that they did therapy over the phone for 23 years.
With postcards and telephone.
But anyway, the telephone can be used. And also, one can transfer patients to another therapist quite easily at this stage of the game, as long as they have developed a trusting relationship with your group. So it isn't necessarily dependent on you as an individual either.
Now, you've said that it's often a crisis which brings the older patient in for therapy. Are there any repetitive patterns in the crisis you see that seem characteristic of the aged?
Well, the elderly widow who has had everything in terms of the practical events of life taken care of for her by her husband. Simple things like going shopping, going into a store and buying things, keeping account of the finances, legal matters. These ladies find themselves completely lost. And what frequently happens is they develop a lot of physical problems. Now they have some bona fide problems, so they go to the doctor and they're treated, and somehow the aches and pains may be relieved, but the problem persists and they come back. I'm thinking of one lady that had a lot of digestive problems, for example. Came into the hospital, was thoroughly studied after the physical problems were kind of taken care of, and she was just somebody thought of doing a psychiatric consultation with this particular patient. And then a flood of, well, I have to have somebody do all these things for me because I don't know how. And what happens is you must teach these people, they have the idea and they're fully convinced that they can't do these things, that they've lost they haven't lost the capacity because they've never learned to do it. So this reflects on them as very inadequate, incapable people, and really this forms a kind of depressive underlying substrate.
Now, are you saying that you can actually succeed in teaching old dogs new tricks, in altering an almost lifelong pattern of dependency?
I'm thinking of a case of a lady who was so fearful of going into a grocery store and picking out the things she needed. She didn't even know what kinds of food she would need. The husband had done even that for her. So the psychiatrist didn't do this, but he arranged to have someone go into the stores with her and pick out things, and then he would see her periodically in between. And she got to be so interested in doing these things, and it was like finding a new life. She was having the greatest time, then picking out things she had really wanted all of her life. So it was like opening up a new life for her and really doing things that she thought she could never do. And then the symptoms really went away. And this is a very commonly repeated problem. It's the elderly widow who has been sheltered and really developed feelings of inadequacy and incapability of handling just the routine things.
I know the emphasis in our discussion here is on treatment, but there are pitfalls in the assessment phase too, aren't there?
Many older people cover up organic deficits very well. They, particularly people that have used their brains, in their life work, for example, school teachers and lawyers, professors, are very good at disguising intellectual deficits and organic problems. And you may, launch into a real abstract form of psychotherapy with these people only to learn that they're really not remembering anything of this. And actually, you're confusing them more. because what they do is they tend to play a game of circumvention. I mean, you ask them a direct question, and they're so skilled at avoiding the answer by circumventing it that you end up thinking that you've gotten the answer, and if you stop to think about it, they've never answered your question. And unless you're flexible enough to see this, I think then you have to switch gears and say, that's wrong, I've got to get into something else.
Which suggests this question to me. Is psychotherapy inappropriate for patients with organic brain disease?
Certainly gross organic problems would not be appropriate for classical psychotherapy. But I've treated people with organic problems using modified, simple kind of psychotherapeutic approaches, mostly supportive in nature.
Right. I think that supportive psychotherapy would be indicated for even somebody with severe organic brain damage in combination with remedial training and reality orientation.
Mm-hmm.
This is the end of side 1. Please turn your cassette over. This is side 2. Here again is Dr. Pfeiffer.
You mentioned classical psychotherapy, Dan. Do you see the transference phenomenon in the psychotherapy you do, and do you make use of it?
Very, very definitely, yes. But the nature of the transference is different. Frequently, what you get into is a young therapist with an older patient, which is the reverse of the situation with the young in most cases. What you're dealing with there usually is a parental figure, whereby what you're trying to accomplish is to establish kind of a laboratory for a repeat of the conflict that occurred in the original with the parents, so that one can get it out and look at it and correct it. All right, in terms of the older person, what you get into is oftentimes what I call either a child, in terms of the therapist, a child surrogate for the patient. The older person forms an image of the ideal grandchild or the ideal child. To you, they see you, once you've established a good therapeutic alliance and working relationship with them, they will invest you with, as a very highly esteemed person. So you become an ideal. And then in that sense, they will relate to you in a good rapport, first of all. And then you're also in a position to use that transference. They will see this younger person with a lot of strength and someone that can help them. They can borrow some of the strength from this young, healthy person, and in some cases to even overcome the therapist. And this older, decrepit, this is the way they perceive themselves, person can overcome a healthy, strong, young person. It reflects that they're really worth something and that they really still are strong. They are still capable. So one can utilize this kind of thing, but the therapist must be aware of this process. So you don't want to get into a power struggle. At times you want to let them win. If you can achieve that, it's really ego building for the patient. The trick is to not become or attempt to become the real grandchild or the real child or the real friend. The contract somehow must be reinforced, and what you're doing should be clear.
Now, what about differences in technique? Are there any?
Touching, physical touching of the patient is something that is, if done properly, is very conducive to establishing a relationship.
They don't have the inhibitions about physical contact that a lot of younger people have. They'll hug you and kiss you. They know the joys, the warmth of physical contact. They don't have to spend a fortune for a weekend encounter or sensitivity group to learn this.
Informality is important in the therapist. I don't think we want to, to use a rigid kind of cold approach.
I find it very rewarding that they are very open and honest. They'll tell you they're hurting, but they'll give it in physical symptoms, and then the more you establish a good relationship with them and the more you talk with them, then you will find out that they talk less and less about the physical problems, and they begin to talk about their feelings.
Also sharing personal information may be important and proper. They may want to know about your family and things of this sort, and I think that's perfectly all right, because they want to know who they're dealing with. as opposed to younger people where you try to maintain a neutral stance. And then you may have to pace yourself down to meet the pace of the older person that you're dealing with. And I think all of us who work with older people realize that. It's a slower process. Mm-hmm. And you have to be aware of that. These traits can be learned and cultivated very effectively and quite easily. But the key issue is you have to like older people.
Right. For a person to work with older people, I think he does have to have a sincere liking and a genuine concern for them. He has to feel comfortable with them. And a lot of people don't. And I think in order to feel comfortable with an older person, you have to have dealt successfully with your own fears of growing old, of aging, and of dying. You have to be able to talk about loss. You have to be able to talk about death. The therapist should have a commitment to the personal worth and dignity of older people. He has to know what's realistic and what's unrealistic to expect. A lot of anxiety in older people is caused by people having unrealistic expectations of them. Say somebody who's having intellectual changes, and other people still expect them to act the way they always have, when they intellectually do not have the capacity to do so. The therapist has to use his own personality in such a way as will allow the older person to see him as somebody who he can trust and on whom he can depend. And the therapist has to have a lot of patience.
And I might add a couple of things to that. It's oftentimes well to see different age groups and not necessarily just limit yourself to working with older people. And what that does, it keeps you honest in a sense. It allows you to keep comparing the problems so that you don't become so absorbed in their problems that it becomes a problem for you as a therapist. And this is a real caution. We found this in our group, as a matter of fact.
Ideally, the therapist should have contact with healthy older people as well.
Right, I agree with that.
To have a basis for comparison, in addition to seeing other age groups.
I wanted to make one point, which I think is really important, and that is the set that the older patient comes with to see the doctor or the therapist. That older people are extremely frightened. They have very distorted ideas about what's going to happen to them when they're oftentimes dragged in by someone else. Or, they may be in a confused state, and they're very resistant and suspicious and distrustful, but they're really hurting. And if one uses that manifest behavior, which is observed, initially, there's going to be a misinterpretation. For example, they may be hostile, they may be really quite difficult to manage, and if you can't solve that problem, then you might as well forget it, because you're not going to be able to establish anything with that patient. So that's the first thing that you have to do, is to find a handle with this patient. And frequently, I call it a tongue-in-cheek collusion approach, which has to do with finding something that's acceptable to talk about for both you and the patient. And in many cases, this may be physical problems. They can't sleep. It gets them so nervous and agitated that they have to walk at night, and then you're already into the emotional problem. You've really got to show them that there isn't going to be a battle, and that what you're there for is really to do something to ease their pain and help them. And if you can do that, you're on the way.
We'll be going into this in much more detail in a later tape, but do you use medication as an adjunct to your therapy?
Oh, yeah. But I don't think it should be used as the basic treatment. The basic treatment should be kind of an overall plan. This should be delineated, and then drugs should be used very specifically to titrate the kinds of behavior that you're trying to achieve and correct the kinds of problems you're trying to correct. For example, you may have a patient that is having such sleep disturbances that it's sapping their physical strength that they really can't function, and consequently, let's say it's aggravating the depression. So you can use a mild sedative, in a case like that. Hyper anxiety may be a noxious, confusing thing in the individual, and certain kinds of drugs to reduce some of the anxiety I think are really appropriate.
One last question, Dan. Have you found that working with elderly patients is rewarding?
Working with older patients is refreshing, and what I mean by that is, particularly in psychiatry and for the general practitioner who oftentimes sees patients that have been they've been to many psychiatrists, and you know, the initial problem has already become so autonomous that it no longer is really the issue, it's something else. When you deal with older people, it's frequently their first contact with a therapist in this profession. So it's a new and it's a fresh, it hasn't been distorted like it is in the usual kind of psychiatric patients. They're really having these things, and it's almost much more textbook in some cases. The gratification that I see oftentimes is, and this was a surprise to me, was oftentimes the rapidity with which older patients get well. Frequently, I've seen patients with severe conflictual problems get well in 2 sessions. And I mean, really, they've essentially resolved this to the point of being comfortable. Some older people have simply learned through living, and they've learned about themselves, and they know a lot more about themselves than younger people do. I mean, you can hardly live 70 years and have multiple experiences and not know more about yourself than when you were 30. There's no way. So in actuality, they have a lot more insight, and they know themselves a lot better. Within a month, many of these people frequently have put it together, and it's an amazing thing, and it's really gratifying. And these people are so appreciative, they just can't thank you enough.
They're very much relieved. A lot of the time it's like, okay, you've got a clean bill of mental health, you know, and they're very happy.
I mean, I'm off doing my thing now. I don't need you, doctor, anymore every week or even every month.
Thank you, Dan and Carolyn. I think what we've just heard shows that it is possible to treat emotional disturbance in the elderly. Using the kind of therapeutic techniques used with adults generally, but making a few simple but very important changes, a therapist can achieve the same good results he expects with younger patients. He can realize the same satisfactions too. The extent to which individual therapists wish to become involved in treating older patients is, of course, a personal choice. But perhaps as one factor which you as a therapist may wish to consider in making that choice, I would like to leave you with a point George Maddox made during one of the conference's plenary sessions.
My favorite future year for purposes of speculation is 1993. That is the year which the Teachers Insurance and Annuity Association reminds me annually is the time when at age 68 George Maddox will receive his first annuity in retirement, if he lives so long. A closer look at the society in which I am and will be going has a certain personal appeal. I regularly remind myself and my colleagues at the Duke Center that we must never think of older people, those that we study, as them, as distinct from us. For to a substantial degree, the subjects we study are us.
As I said earlier, the purpose of these tapes is to try to share more widely some of the successful techniques for treating the elderly mentally ill which are available now. Still, as George Maddox and my favorite political commentator, Pogo, have both observed,
We have met the enemy and they is us.
it's an interesting idea for therapists.
Thank you, Dr. Pfeiffer. This audio cassette tape series on the successful treatment of the elderly mentally ill is brought to you by Wyeth Laboratories and the Duke University Center as a service in continuing education. Participation by discussants on this tape does not imply endorsement of Wyeth products, and the opinions expressed by discussants are their own. Other tapes in the series deal with group psychotherapy and the somatic therapies as they apply to the elderly. We hope you'll find them useful.